Bismillah ar-Rahman ar-Rahim. Thank you, all of you, for the attendance. And thank you for our guests, our presenters. Really just quick look regarding the history and the future and what's on the way. This is simple procedure which can be done by one radiologist or technician, and even without cooperation with the patient. And if you go back to the history, for even T1 breast cancer, we embark on the not modified radical, it is radical mastectomy, which we removed everything regarding the axilla, regarding the lymph node, regarding the vein, regarding the nerve, regarding even the pectoralis major. After that, the matter changed to the more conservative management. Now for the simple, after staging of the patient, now for the early cancer, we'll doing simple BCT, breast conserving therapy, and the sentinel lymph node biopsy. This is also applied for the thyroid. If you can see, previously, when we touched the thyroid, our plan was to do a total thyroidectomy or near total thyroidectomy or subtotal thyroidectomy. Now the matter is changing for the lobectomy, or even preserving the isthmus, which is called host surgery. Now also we are doing the nodulectomy. This is also changed to another point, which is minimally invasive surgery, like in the Toitiva or endoscopic mini invasive surgery, which is approaching from the oral cavity, from the axilla, or from the post-auricular area. Now, inshallah, we have a conference in Thailand. After a few months, we have a training over this part. And alhamdulillah, also we did Toitiva in our center here. But still, we need more training for this scarless surgery by the minimally invasive surgery. So, how to compare between the previous history of the management and now? Previously, we did total thyroidectomy, even with the neck dissection, central neck dissection, for the PTMC, papillary microcarcinoma. Now, it is well known in every guideline, from Pacific through the ETA to the ATA, American Thyroid Association, European Thyroid Association, British Thyroid Association, Pacific Association also, is active surveillance. So even for the PTMC, less than 1 centimeter, we can do follow-up for the patient without surgery. So even the cancer or microcancer, no need surgery, no need to be touched. So the matter is changed a lot. What's new in this field is a non-surgical technique by the ablation. I agree with this. Instead of keeping the patient for the active surveillance and the follow-up and wait for the lymph node to develop, or metastasis, or capsular invasion, or they become larger than 1 centimeter, why not to ablate it? This is a very good idea. The patient refused surgery, although even for the microcarcinoma, I must surgery in the form of the nodulectomy, which you are practicing it now, or in the form of the lobectomy, or if it is multinodular or multifocal, better to do a total thyroidectomy. If the patient refuses all this, to avoid the scar, the best option is to do what? Is to do ablation. By this, we are getting rid of the tumor and follow up in the patient after that, after it become necrotic, and you are stopping progression of the tumor. So there's a lot of papers talking about the side effect of the surgery and the advantage of the microwave or the radiofrequency ablation. طبعا some talking about the hospital stay, duration of the surgery, complication of the surgery in the form of the vocal cord change, in the form of the hematoma, in the form of the hypocalcemia, in the form of the scar, pain, cost, everything. But still, the surgery have a cornerstone for the treating of the multinodular goiter or for the large goiter and for the other pathology with the patient's complaint. If you compare between the minimal invasive surgery and the super major surgery or major surgery even, طبعا you will find the surgery have a higher rate of the complication as compared to the minimal invasive surgery. This is well known. We don't have much hematoma, we don't have much blood loss, we much have pain, scar, cost, stay. Yani even the post-operative stay should be about 4 days. And the operation time is more than 1 hour. Instead, microwave is lasting only about, in average, about 20 minutes, and the patient no need to stay overnight. So the difference is that we have a lot of change between the operation and the microwave regarding the complication. This is a scar of the patient. This is after antenna, which is entering the side. After failure, they proceed to the surgery. You see the difference between the two scars. This is the scar of the microwave and the scar of the surgery with the drain, طبعا. This is how to approach percutaneously into the side of the lesion, and if you want to ablate it. A lot of data talking about the also thyroid function test after ablation and after surgery. طبعا the same in general. If you do, for example, lobectomy or nodulectomy, or you'll ablate it, the thyroid function test will be the same after total thyroidectomy. If you replace it, although you suspect the thyroid function test is not changing. So there is no change between the both procedures regarding the thyroid function test. Radiofrequency ablation, reoperation for the benign thyroid nodule that developed after previous thyroid surgery. I agree with this. The best option for the patient who develop thyroid nodule after surgery, the best option is the ablation. I agree with the ablation for the recurrent goiter, especially recurrent toxic adenoma, recurrent toxic multinodular goiter. What else? Surgeon. In which situation you prefer to send the patient for the radiofrequency ablation? Our head and neck surgeon, please. Unfit, barakallahu fiqh. Unfit patient, yes. What else? Refusing surgery. What else? As we said, the recurrence. Palsy, one side is palsy. Recurrent cancer or MTC, especially if it is developing inside the lymph node. Yani lymph node recurrence, and you cannot retouch it again, especially in the single and in the sensitive area, especially if you have a contralateral palsy. What else? The patient with the low calcium. Very good. So in general, we prefer to send the patient in the form of when the patient come back as a recurrence, the patient's old age, unfit, refusing surgery. If the patient have a recurrence of the malignancy, if the patient have a single lymph node, you don't want to reopen the patient for the sake of the single lymph node. In this situation, better to ablate the thyroid and the lymph node and the recurrence by the microwave, or by the laser, or by the radiofrequency ablation. All we agree about that, because the risk of the complication after resurgery is too high, reaching about 30% for the nerve injury, reaching about 20% for the hypoparathyroidism, according to the previous, depending on the previous surgery. Risk of the hematoma, risk of the complication, risk of the tracheal injury, esophageal injury, failure of the procedure is too high in the recurrent thyroid surgery. So in this situation, as we told that we preferred microwave or the radiofrequency ablation. This is microwave ablation for the papillary thyroid carcinoma. If the patient refuses active surveillance and the surgery, I think the best option is microwave ablation, but the local recurrence is about 4%. I don't agree with this, because if you do good surgery, there should not be recurrence after surgery. So the rate of the local recurrence is high in the form of the. Now, alhamdulillah, barakallahu feek, Dr. Aras, now we starting ASA, aspiration, ethanol or sclerotherapy, ablation. We have, alhamdulillah, a lot of patients, and I noticed that when the patient have a large thyroid cyst, he develop hyperthyroidism. By this, we will ablate the cyst, and it will shrink. After that, we will get rid of the hyperthyroidism and the cosmetically G2 and G3 appearance of the patient. So this is regarding the thyroid. Still, I'm with surgery. For every type of the pathology need intervention apart from this situation which we mentioned. Regarding the breast, we have a lot of pathology. Now we are interfering for the fibroadenoma. The microwave is useful in this field. Those patients who refer them to the Dr. Alana and for the radiologist for ablation, those very old age, unfit, young age, with the recurrent fibroadenoma or with the multiple fibroadenoma. Then the tumor should be around 2 centimeters plus minus. In this situation, we get too much benefit from this because we are avoiding the scar, avoiding recurrence, and even if there is recurrence by the same antenna, we can do re-surgery and re-ablation for the patient. So there is a lot of trial talking about. One of the paper is very strange, talking about the microwave ablation for the cancer cases. I don't believe in this. Less than 5 centimeter cancer can be ablated by the ablation by the microwave. I don't believe in this, really. And this is a risk for the patient. I agree if you tell me that the patient have a very small cancer and the patient is unfit or she refused surgery, and you are waiting for for example, chemoradiotherapy or the hormonal therapy. If you start with the ablation, just like a neoadjuvant chemotherapy, after that you'll do surgery, I agree with this. But given a trial of ablation for the macrocarcinoma in the breast, this is illogic, and this is unacceptable to me at all. So in general, I agree with the microwave ablation.
Doctor, you have 2 minutes.
Followed by the breast conserving therapy. I agree with this. And you see a lot of result, ablation for the old female, and we see we can see a cavity after 6 months follow-up. So and another one, they are talking about the radiofrequency ablation for the elderly patient who are not fit for the surgery. Although we are doing these under regional or under local anesthesia with the sedation, we are not waiting for the general anesthesia and the patient to be fit, but still there is a trial, and those who refuse surgery because of the, this is another contraindication for the surgery because of the myocardial infarction, diabetic hypertension, and the patients are unfit. They did surgery, and 2 patients of them are died because of the cancer, and 2 of them are died because of the comorbidity. So in general, we agree that for those who are unfit or refusing surgery, or the patient with the multiple fibroadenoma, or the recurrence, or the young age, or the extreme of age, for example, very old, which is unfit, we agree with the ablation. Apart from this, the best option is a surgery for the patient. Okay, so this is the cancer before ablation, and this is a cancer after necrosis and ablation. You see, this is after surgery, and they remove it and they expose it. So the future, I think, is for the microwave and the radiofrequency ablation. I hope every center in the Suleimania or in the Kurdistan in Iraq in general must have this equipment for the ablating of the liver metastasis, lung metastasis, and other part of the body. And if they have a well-established center for the thyroid and the breast, they must have the either microwave or radiofrequency ablation. We are, as a surgeon, we like surgery. Radiologists. I think histopathology also with us, huh? They dislike ablation because they don't have histopathology. So, كل حزب بما لديهم. We have shaqo, we have blade, and we like our surgery, and we don't want anyone to compete in our field. I think in the future, for the surgeon and the histopathologist will be like that. And I hope that we will not go home to have this where our blade is. Thank you very much for listening.